Okay, good afternoon, everyone, and welcome to our Lunch and Learn webinar on improving bowel cancer participation in your practice. My name is Ruby Van Kool, Cancer Prevention and Control Program Officer at CESPHN. Also with us from CESPHN is Linda Silva, the Digital Health and QI Program Officer, and we also have Lauren Thomas from the CPD team. I'd like to start by acknowledging the traditional custodians and sovereign people across the lands in which we work. We recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. So just a bit of housekeeping to start with. Please note that this webinar will be recorded and it will be available on the CESPHN YouTube channel within the next couple of days. Your audio and video have both been disabled. However, if you have any questions during the presentation, please use the Q&A function. We will come to your questions at the end of the presentations. An evaluation will also pop up at the end of the session, and we really appreciate if you can fill this out. We really appreciate hearing your feedback, and you will be able to self-report this as education with your governing body. These are a couple of upcoming events that CESPHN are also hosting, including a webinar on the new National Lung Cancer Screening Program, which launches on the 1st of July. You can register for these by scanning the QR code or heading to the CESPHN events page. We will send you these slides after the presentation, so you can always scan the QR code afterwards. So CESPHN offers a broad range of support services for your practice. If you require any help or you want to know more about what's available, please reach out to your practice support. So these are the learning outcomes for today's session. Our goal today is for you to leave with actionable tasks you can apply in your practice. We'll cover the functions of the NCSR, identifying patients due for screening, and implementing recall and reminder systems. We will also just flag some common data limitations, especially when it comes to family history and colonoscopy. So before we move on, we're just going to do a quick poll to look at what you currently know about bowel cancer screening. Your results are anonymous. We can't see who's completing it or what your answers are. So it'd be great if you can just pop your answers into the poll. So maybe if we move on to the second question now. Okay. Sorry, I don't know if that was popping up for everyone. It's just popped up on my screen. If everyone has a chance to answer both of those questions, just give you a little bit longer. Okay, I think we can probably look at the results. Okay, amazing. So the first question is 40%. So a lot of you answered 34%. So it is 40% nationally, and everyone was right that all of the above. So they're all risk factors for bowel cancer. Just close that. Okay, so despite bowel cancer being one of the most commonly diagnosed cancers, we now know that participation is still quite low across the country. And when we look more closely at our region, the participation rate is even lower. So this is where the National Bowel Cancer Screening Kit comes in, which aims to reduce death through early intervention using an IFOBT to find tiny amounts of blood in the stool. So this is an image of what the kit looks like that are sent to patients. And it involves collecting 2 small stool samples, which is done at home. The samples are then placed in the tubes, sealed in a replied paid envelope and mailed to the lab for testing. So all people aged 45 to 74 are eligible and encouraged to screen every 2 years. So if you didn't know, the age range did reduce from 50 to 45 at the 1st of July 2024. However, how a person receives their kit does depend a little bit on their age. So people aged 50 to 74 are sent a kit every 2 years automatically, and this is sent to their address listed on Medicare. Those aged 45 to 49 have to request their first kit. So this can be done either online or by calling the National Cancer Screening Register. Practices can also provide kits to patients using the alternative access to kits model, and we'll go through this in a bit more detail later in the presentation. And then regardless of how they receive their kit, so whether that's through the mail or through the practice, they'll automatically receive their next kit in the mail 2 years after their previous kit was completed. So primary care plays a really central role in preventative health, and bowel cancer screening is no exception. So encouragement and guidance from GPs has been shown to increase participation in the National Bowel Cancer Screening Program. So a simple conversation during a routine appointment with a GP or a nurse can be what encourages someone to return their kit. Primary care staff also play a key role in quality improvement initiatives, and that's a lot of what we'll be going through today. And GPs are also really crucial in ensuring that patients follow up with any further assessments or tests as required. So as I mentioned, the activities we're running through today are all part of quality improvement in general practice. By embracing QI and refining processes, you can ensure improved patient outcomes and overall practice performance. So these are the 5 key strategies that we'll be walking through today to look at improving bowel cancer screening participation in your practice. So we'll be looking at cleaning data, assessing your current bowel cancer screening rate, engaging both from a patient side and also education for GPs, implementing clinical workflow enhancements, and then reviewing your progress as you go. So the first step is to clean your data. This ensures that you have an accurate and reliable list of patients who are due for screening. So key actions include removing duplicate patient records, inactivating patients who haven't visited the practice for a certain amount of time. So this time period will depend on your practice policy, reviewing and updating family history and colonoscopy. And while it's not directly cleaning data, but more in terms of data completeness, we suggest integrating with the National Cancer Screening Register. And this is also something that we'll go through a bit later. Step 2 is about assessing where your practice currently stands with bowel cancer screening participation. Practices in the Central and Eastern Sydney PHN catchment who participate in PIP-QI will have either Cat4 or Polar. These can help you to find your baseline, identify gaps, and track your progress over time. And we will now move on to a practical demonstration from Linda.
Thank you, Ruby.
I'll just stop sharing.
Thank you. I will start with Polar and then move on to Pancake. Share my screen. So hopefully we can see my Polar demo page. Okay, so cancer screening data about your practice are in the QIPC clinic report. So I'll head over there. The QIPC module applies an automatic RACGP active filter to your patients. So it only looks at patients that come at least 3 times in 2 years. So your regular patients, so to speak. Clinical data about cancer are under the clinical menu, cancer screening. And I will head over to the bowel cancer screening tab. Not a load. Okay. Okay, so this report shows us how many patients of a screening age we have altogether. So that would be the last cohort button called total due and not due for screening, which we have, this clinic has 4,192. And the other cohort buttons going from left to right show us patients in subgroups. So the orange button shows patients that are due for an earmarked for urgent screening. So that would be due to their family or personal history of bowel cancer or history of polyps. Then the second to the right, that's patients that are due for screening right now. And the third one are patients who are up to date. Right underneath, we have a cohort table. And so currently we can see all 4,192 patients who are either due or not due for screening. But by selecting the individual button, such as the urgent screening cohort, we can have a closer look at patients in this category. So scrolling down, we will identify patients who are identified as urgent screening required based on, let's say, this patient has a personal family or family history of bowel cancer and also history of polyps. Underneath, there's also a chart with tests that have been performed for this group and on record at your practice. So we can see that 14 of those 18 patients never had any screening done, at least at your practice. This could change if you integrate with the National Cancer Screening Register and check those patients against the national data, because you can enter certain screening records manually. So this group can actually reduce if you first do a data completeness exercise. And that at the end, we have your bowel screening improvement progress over time, which is if I select the total number of patients. So this serves as your benchmark. So if you are starting a quality improvement activity, you would be looking at your starting benchmark, so where you are now, and compare your improvements to that. So you can pick up the 20% as your starting point from the line chart below. If we look at, we can also change this table into an Excel spreadsheet, so it's easier to work with. So I'm still on those 18 urgent screening required patients. If I press the patient list, it will come up with a list in a bit more workable format. And I can further export it to Excel and save it to my desktop or print it out. Going back to the report is easy. Just press the button back to the report, and that will allow you to continue flicking through different selections. Your filters are always displayed at the top. So if I'm ready to move on from the urgent screening cohort to the non-urgent, I'll just use the cross and get rid of the current filter and select the non-urgent patients. We can see once it loads that it's over 2,000 patients for this demo clinic. So it's probably a really large cohort to work with. So we can think of filters that would reduce it, and we can drill down to the most interesting or urgent patients. So on the left, you have a filter column. So you could think of applying a chronic disease group filter, such as diabetes, which we know that type 2 diabetes is a known risk factor for colon cancer. So if you press the button, it will reduce the number of patients in that cohort significantly. And I already have 845, and the list of names is loading. Also, what can make sense to you is to just filter by clinician. Maybe you have a GP lead who is running the bowel cancer screening project. So we could also look at patients that are the usual GP or the most seen clinician. Again, so that reduce the number of patients even further. Another thing you can also consider is maybe approaching the patients that are new to screening, so the 45 to 49-year-olds that might not be aware that they could screen, and apply an age group filter for 45 to 49-year-olds. This group can be also cross-checked against other criteria. You could consider having a look who is also a good candidate for a 45 to 49 health assessment. So you would essentially be comparing two lists together. So now I have 59 patients under one GP who are 45 to 49. We know that they access to the screening kits would be the alternative model. So maybe it would make sense to head to the tracked NBS report and also have a look how many patients are eligible for a health assessment. So this is another predefined report for 45 to 49-year-olds, but it picks up based on your NBS data how many patients will be eligible for a health assessment. So here I have 36 patients that could be recalled for a health assessment, and bowel screening conversation can be approached opportunistically during those appointments. While we are, I'll just unclick this button to get myself the whole bowel cancer screening cohort again. So while we are in this module, it also makes sense to get a sense of the overall data quality and completeness we have for these patients. So if I go to, again, under clinical, we have a data quality module. You might be familiar with it already if you prepare for accreditation. So I'm sorry, it will load in a moment. It's a table with accreditation indicators, including family history, BMI, alcohol, and smoking. So I'll just give it a moment. It's very slow today. Yours won't be this slow. This is just a large demo database. I'll try again. It's not loading for me today. I apologize. Okay, maybe now. Okay, so just wanted to point your attention to this table because it can help you with accreditation prep, but also you'll get a sense of the risk factors for bowel screening cohort, such as smoking, alcohol, BMI, and family history. And it's in a traffic light system, so it indicates where we are really short of the RSCGP targets, which is 75%, except for allergies, which is 90%. So I will now move on to PenCat and show you the features and how to identify them. So, so Ruby, please indicate if everyone can see.
Yeah, I can see pen.
Fantastic, thank you. So with PenCat, our starting point would be filters. So we have to manually enter 45 to 74 and RACGP active filter and recalculate. Then we can head on to the screening report. FOBT last recorded tab. So again, if I select the never screened cohort, I have over 1,000 patients. I can identify them by hitting the export button, which will bring up a patient list on the screen. However, if this feels a little bit too big to approach, we can actually think of other filters to add to this. So let's say if we head back to the filter tab, we can look at the risk factors and filter by obesity, someone who has a high BMI, and recalculate. Okay, so now our cohort is smaller. We only have 373 patients. We can keep adding to this. Let's say our question could be, how many of these patients also have a chronic disease and are eligible for a care plan? I will keep this selection open, which is indicated by the dot next to the screening report. And then I will combine it with the NBS eligibility report. So if I look at how many patients also have a chronic disease, which is either diabetes, CVD, or chronic kidney disease, I'll select care plan eligibility and these 83 patients. And then I can use a very, very useful feature of PenCat, which is combining reports. They call it cross-tabulation. So I'll hit the report button, and hopefully you can see what opened up is a very manageable list of 44 patients who come to the clinic on a regular basis, are of the bowel screening age, don't have any results recorded, and they are also eligible for a care plan due to having an existing chronic condition. And so that's one approach. If another approach could be going back, just focusing on cancer screening, and maybe you already run a successful cervical screening program at your practice. So you could look at patients who are due for more than one cancer screening program. Again, I'll keep the FOBT selection active and then have a look at cervical screening. If I also select how many patients are due for cervical screening and combine these two data sets, what PenCat returned 66 regular patients that are due for more than one cancer screening program. There are many strategies you can use to actually set a goal that's achievable and that you can achieve within a time frame. And that will depend on your priorities and on your unique practice. You don't have to, any of these steps that I've shown for PenCat and Polar, you don't have to remember those. You can book a session with your digital health officer who will help you get this patient list, help you with the NCSR integration, data cleaning, data completeness, all of that. This is more a showcase of the data you can get from your data extraction tool to help you think about the individual cohorts you would like to approach. And again, before we move on, it's good to also get a sense of data quality from PenCat. So if I go to data cleansing and have a look at missing clinical and accreditation items, let's have a look at items that are relevant for bowel cancer. So I can't see family history here. So what I'll have to do is right click above the line and edit manually, double clicking on family history. And now I can have a look at how many of patients of bowel screening age are missing a family history or another important risk factors such as BMI, alcohol, or smoking. So that would be the data completeness quality improvement you can undertake before you embark on a bowel screening QI. I will hand over to Ruby now, but if there are any specific questions on Penhead or Polar, please post it in the chat. I can get back on at the end and answer them during the Q&A. I'll stop sharing now, Ruby.
Thanks, Linda. Okay, I will just share my screen again. Okay. So now moving on to step 3 of the strategies that I introduced earlier. We're looking at patient engagement. So many patients may delay or avoid completing their bowel cancer screening kit due to stigma, fear, or misunderstanding. So conversations with healthcare providers can really help to normalise screening and address any concerns patients might have. And something else that we do suggest is including a prompt in health assessments or care plan templates, which can provide an opportunity and timely reminder to ask about screening. So as Linda showed, it's quite an easy way to extract a list of patients that are due for bowel cancer screening and also eligible for some sort of care plan or health assessment. So that's a really great chance where you might have a bit more time to discuss these preventative health screenings. Another thing is practice promotions, so displaying posters and having brochures available in waiting rooms are an easy way to prompt actions. So there are a lot of existing resources available online, and these are free to order and have delivered for your practice. There are also specific resources for Aboriginal and Torres Strait Islander and multicultural populations. So if you have quite a large cohort of patients that are non-English speaking, there are a lot of translated material available. Now, in terms of CPD for staff, there are a range of online education modules that are CPD accredited and designed to support your knowledge and confidence in bowel cancer screening. So as I mentioned, these slides will be sent following the session, and I'll have the links available if you're interested in enrolling in any of these. And for practice nurses, there is one specifically from APNA. As mentioned earlier, integrating with the NCSR can improve your data quality and also really help to streamline your workflows when it comes to bowel cancer screening and also cervical screening as well. The NCSR is a centralized national database that stores all screening participation and results. So you can integrate with the NCSR, which means those screening results are available within Medical Director and Best Practice. So once you open a patient's record, you'll see the toolbar, the sidebar with the National Cancer Screening Register, and you'll be able to see if they're due for screening. You'll be able to update their information. You can issue kits to be delivered directly to their home, or as mentioned, you can issue a kit via the Alternative Access to Kits model. So we strongly encourage practices to use the National Bowel Cancer Screening Program kits compared to private pathology kits. So that way all the results are stored on the NCSR, which is a centralized database. As Linda mentioned, if your practice is currently not integrated or you need some help with, getting the most out of it, then please get in touch with your digital health officer or the digital health team for any sort of troubleshooting. So as I mentioned earlier, the Alternative Access to Kits model is designed to increase bowel cancer screening by allowing practices to bulk order kits and issue them directly to eligible patients during appointments. So this model allows you to offer the kit while the patient is already in the practice. So that way you can demonstrate how to use the kit if required. And we also know that people are more likely to complete the kit after discussing it with a healthcare provider. So I will just give a quick overview of how you can order kits. And as we mentioned, if you need support with this, you can reach out to myself or the digital health team, sorry. So to order kits, you log into the NCSR health provider portal using your PRODA credentials. You select the IFOBT bulk order, and it's just a short form to complete, and the kits will then be sent to your practice. Just be mindful that kits do have a 7-month expiry, so just consider this when calculating how many kits you need. And it can take up to 4 weeks to have them delivered. Once you submit your form, you will be provided with an order number, so you can always follow up if you don't receive your kits. So once your practice is integrated and you've received your bulk order of kits, you can then easily issue a bowel cancer screening kit to an eligible patient during a consultation. So as I mentioned, so this is how the NCSR will look once it's integrated within either best practice or medical director. So you can confirm the patient is eligible and due for screening. You can then click on the form and reports button here, and then select the bowel kit issued by healthcare provider form. You then complete the form and press submit. It's really important to register when you give these kits out to patients, because this then prompts the NCSR to send reminders to patients as well to make sure those kits are completed and returned. Something else that's really important to note is that even though you press submit, you do need to print the form and also provide it with kits. So in the past, we've had GPs which have been really proactive in handing out kits, but you also need to make sure that you're printing the form so that when it is processed by the lab, they can track exactly who's completed the form and where the results need to go. So once you've submitted it, you can just refresh the NCSR by clicking this button. You then go back to NCSR history, and there'll be an option that says print or reprint participant details form. So you download that form and print it and provide the completed form and the kit to the patient. And something to note as well is that practice nurses can also issue these kits to patients. They will need to have delegate access set up through PRODA to be able to issue those on behalf of a healthcare provider. And the NCSR do have some really great walkthrough videos. So again, these will be sent following today's session, and I'd encourage you to check these out. They're only about 20 minutes long, and it does go through the bowel cancer screening program and also cervical screening, and provides a really good walkthrough of all the available forms and functions of the NCSR. So number 4, another thing is that this is a really great opportunity to review your current recall and reminder system. So when you look at your setup, you may notice numerous free text reminders. Start by cleaning up these free text entries and decide on the use of coded, predefined reminders within your system. So these are some examples on the screen of what that might look like. The aim is to systematically remind all eligible patients about bowel cancer screening. Often we're only reminding patients who have completed a kit before, often overlooking those who may not currently be screening. And a great way to monitor and record your quality improvement are the QI templates that can be found on our website. There are some pre-filled templates and other resources to help you on your QI journey. I will also have a template sent out to all participants following the session. They serve as great evidence for CPD hours, accreditation, and the PIP QI. So this is a picture of what the first page looks like, which is identifying your QI team, everyone's roles and responsibilities, and you can identify your goal, looking at your baseline and how you're going to track or measure your improvement. The second page is a PDSA, which you can complete throughout your QI journey. Quality improvement achieves the best results when it's a team effort. So GPs can act as the clinical leads and sponsors, while nurses and non-clinical staff bring their expertise with the systems, the workflows, and the data audit tools. So as Linda has mentioned, if you're a small practice or you're yet to have a QI team, please reach out to the PHN. We're more than happy to help you with this quality improvement work. So some key takeaways from today's session. One is to integrate with the National Cancer Screening Register. It supports real-time screening data, easy kit ordering, and allows you to issue kits directly to patients. Use your clinical audit tool to identify patients aged 45 to 74 who are due or overdue for screening. And as Linda mentioned as well, please get in touch if you need help drilling down to a feasible amount of patients to follow up. You can then decide whether you might send SMS reminders or prompts to patients, or whether you discuss this opportunistically as they attend for other reasons. June is Bowel Cancer Awareness Month, so it's a really great time to get started on these bowel cancer screening activities. So if you'd like to contact Digital Health or someone from the cancer prevention team, please use these emails or phone numbers. We're here to support you through every step of this project and collaborate as part of your team. So if you need help with the NCSR integration, how to order kits, setting up recalls, or launching your QA activity, we're more than happy to help. And I'll now open the floor for if anyone has any questions. So I think the question is, can we use private FOBT instead of the kit? So the reason we do encourage using the National Bowel Cancer Screening Kits compared to a private kit is that way the results are stored on the NCSR, so it makes it a lot easier to look at screening history over time. So private kits, the results will go just back to the practice and stored on the practice's local clinical information system. So it does mean, for example, if that patient moves around, there isn't necessarily any way of tracking that. Okay. Well, yeah, thank you again. And please feel free to reach out to Linda or I if you do have any questions following the session, or if you'd like some help getting started on bowel cancer screening within your practice. As mentioned, and I think Lauren might have popped it in the chat, there is an evaluation survey which we'd appreciate you completing, and you can record this time with your governing body. Thanks so much.